Good afternoon. Thank you, Dr. Khanna, for giving me this invitation. It's always a nice feeling to be part and parcel of non-coronary interventions, having coronaries at heart. I'm just showing you one case of carotid. This was a 35-year-old lady. Basic diagnosis is aortoarteritis. She presented 8 months back with tingling right leg and hand and some kind of blackouts. Color Doppler done that time showed us subclavian arteries showing critical narrowing, and feeling was that she had a stenosis. This particular movie unfortunately is not running, but this was about 6 months back, and she had a only surviving artery to the brain was a right vertebral artery, from subclavian to vertebral, and there was a critical 95% stenosis focally just at the origin of the right vertebral artery. The family somehow was not very convinced that she needs intervention procedure. She went to many doctors, including many who felt that the ESR and CRP elevation was a contraindication for a percutaneous procedure, which may be correct. She presented in March with right-sided weakness, and she had some improvement, and we all felt that we must wait for about 3 weeks at least, since the brain scan showed a significant damage during the scan. This was the angio done that time, and as you can see here, there is a total block of the innominate artery. So there were lots of thought as we discharged her because of recent stroke, and it was overall felt by the neurologist and the endovascular surgeon that nothing can be done percutaneously and she should go for surgery. So this is actually pictures about 3 weeks before we did the intervention procedure. This time she came with drowsiness. She was localizing to pain, but there was extreme weakness on the right side. It was almost grade 3. There was some speech defect, and this is an angiogram which shows that there is a total block of the innominate artery. At this stage, there were many thoughts crossing everybody's mind. One was to quit, and we actually worked with a couple of wires. I think we took across 200, which didn't go. Then we took a Shinobi wire, which is passed upwards with a support by a balloon. And after doing some dilatation, this was really an encouraging picture that we saw. So you can see that lower down you see a reasonable artery, thin strand like carotid artery, and then you can see the upper circulation quite well. Mind you, till this point, though we were moving with a wire and a balloon, we did not know whether we were in the carotids or whether we were in the vertebrals. My own feeling was we were in the vertebral till we took this picture and we realized that we were in the carotid. So this was the right carotid, actually feeding the entire brain circulation, and something which we thought we can achieve now beyond this point percutaneously. It was not too difficult working from this point onwards. We switched to so actually this is what we started with, and this is where we are, and now we feel that we can achieve a percutaneous intervention completely. So over the wire we put a spider distal protection system, and then we have first stent being deployed. As you can see, just back to back we bring in another stent. These are all self-expanding Cordy stent. And then we have a very good looking expansion of the carotid artery. We needed to supplement the tail part of the innominate artery with another small genesis stent at the origin of the total obstruction. So this was the deployment of the third stent at the bottom. Then we retrieved the distal protection device. This was a spider, and I think this is our final picture, which actually opacifies the entire brain circulation quite effectively. So most of the time, total occlusions is big no to carotid intervention. A thin strand like carotids, we all say that it's going to be no fun trying to address this vessel. But this vessel was we thought amenable. The important issue is the patient has made, in clinical terms, almost an 80% turnaround. She's able to walk, talk fluently, taking great interest in the surrounding and so on. So I leave it to you to decide whether we continue to address some of these total occlusions of the carotid. But I have a friend in Taiwan, and we've had 2 or 3 meetings with him. He uses a kind of a special perfusion brain scan, which to me is like thallium for the cardiologist, which tells us that if you reperfuse the viable muscle as it generates in the heart, it's also going to generate in the brain, right or wrong. I'm nobody to answer, but I think I learned a lot from this case. Any comments, or we go on to...
How old was this?
She's 38.
This total occlusion was for how long?
I would imagine it's about 4 months.
I believe there's a very, very interesting case, quite challenging and daring at the same time. So there should be some question. I would like to put one question, that okay, you think that it is 4 months, and when you are recanalizing the innominate artery entering into the carotid system, question remains the possibility of embolic condition coming up during this phase. And and after that you have done your balloon dilatation, you have opened it, then you are placing now a protection device. I mean, I don't know how far is the utility of it, or
I get your point,
must that has to be done?
Yeah, actually, Shirish, I also had a similar related question. See, we know that the etiology we are dealing with Takayasu's arthritis, and it is quite different from atherosclerosis. And as Dr. Dhar has pointed out, you have probably gone through the difficult part anyway. And these arteries are like leather, having operated on them surgically in acute phase. By the way, this is the only indication in Takayasu's arthritis to intervene. You were absolutely right in the beginning to suggest whenever cerebral perfusion is compromised, you must go in whether the disease is active or not. So anyway, that was different. But should we have put a filter anyway?
We did.
That is the question. No,
No,
you did, but should it have
you
been?
did,
That's
but
the question.
whether, I mean, I find the justification, my question, you have already poked to it, if there was embolization to take place, that has already taken place, and what did your cerebral CT scan or something, if it was performed later, what did it show? Was there any new infarct area or something?
No. There was no new infarct area. We
Okay.
did a cerebral CT immediately after the procedure. It showed contrast stain, as they call it, and we did
It is only the
6
thing
hours
is that
after.
once you are opening, it is same thing. We do not go to open a totally occluded carotid artery. Usually we don't, and it is practically just to save practically a situation for her cerebral circulation. You are doing something. You are doing very daring thing. But once you have been successfully opened it and you have balloon dilatation, you have done. After that, again putting a
No, I look at it this way, Dr. Dar, that
Michelle, what do you think?
so many times we get a very, very critical block,
Michelle, what do you
and
think?
the angioguard device is unlikely to go.
No.
So we put a balloon over a small balloon, what we call is a pre-dilatation before we put a protection device.
Yes.
So I would imagine it's something like that.
Yes. 2 points. I think that for arteritis, maybe a protection balloon is not indispensable. A protection device, excuse me. The second point is, I think that occlusion, carotid occlusion, is a next step for carotid angioplasty, because when you do a carotid angioplasty, you improve the brain function in half of the patient. That means that when you have a patient with a total occlusion of a carotid artery, with a brain function which are very reduced, deteriorated. I think it could be indication if you can prove by some test, imaging that the brain perfusion is reduced. So there are indications, and in Taiwan I know the cardiologist who does this procedure. I think that's maybe a good procedure for the future.
Absolutely. Okay.
Fascinating, absolutely fascinating. I think we'll request you to deliver your second talk on carotid endarterectomy versus carotid stenting.
So I think over length of time, the NASCET and the ACAS have clearly proved that surgery is better than medical treatment. And in came in 1981, Matthias doing the carotid stenting as a competition. So today we are talking whether percutaneous procedure is going to be better, equal or worse compared to angioplasty. Whatever we conclude, world over the carotid angioplasty numbers are growing and the surgical numbers are dropping. This actually was set in with some initial studies which were favoring surgery. Then came some studies which were equivalent, and then came studies which favored percutaneous intervention. And I think we must all credit it to SAPPHIRE study, which was actually a non-inferiority trial which ended up being better than carotid artery surgery. I think the percutaneous intervention really got a boost when we all started using protection device. The protection device really changed the scene for percutaneous intervention. But 2005 came the EVA 3AS, and then around the same time SPACE came up, and these were two real bombs to the percutaneous intervention procedures. We all know that the end protection device has their own limitation like spasm, dissection, wall opposition, and so on. However, over the last many years, we continue to do cases which are fairly complex, like this case was recent 3-day back symptoms with a thrombus. I don't know whether you're able to appreciate, but thrombus which was addressed with device and stent. So when we do screening on ultrasound, I think you can pick up high-risk blocks which are at a risk of distal embolization. And if you use the proximal protection, I think it becomes number one choice for lesions which are heavily thrombotic, which are likely to embolize distally. The proximal protection, as you all know, can avoid embolization at all stages during the procedure. And the results, if you see, compare it with the conventional protection, they are very, very comparable in short term as well as the long term. So the strong point for proximal protection is protection even before anything crosses the carotid lesion. And this, I think, is a very strong point in favor of proximal protection. Proximal protection over a length of time has been used for high-risk lesions, more challenging lesions, all kind of tortuosities, no more an issue with proximal protection. So anatomically more complex and complex lesions are also included once we can address proximal protection. Is there a kind of disadvantage in proximal protection? Yes, of course. The proximal protection is not tolerated by about 5 to 10% of cases. Over a length of time, the percutaneous intervention variously has improved, and we have something like a Rubicon filter, which is just like our coronary O14 wires. We've been able to address very tortuous lesions with difficult access. This was a patient who had no groin access, a critical lesion in the carotid, and we actually went from the arm, looped the guide catheter into the carotid, took a support at the bottom of the common carotid and addressed the carotid artery. This was such a critical lesion that initially even a BMW wire was unable to cross this lesion. We had to use whisper wire to get in. We did some pre-dilatation, got the angioguard protection in, and then we worked on balloon and stent. And these are the things which you may have to do many times, like this critical narrowing needed a pre-dilatation with a 2O balloon before we could get a protection device inside. So overall, when we talk where to use proximal protection and where to use distal protection, if you have a standard anatomy, a low, medium risk for embolization, you can continue to use with distal protection, which is a little bit more user-friendly compared to proximal protection. If you have complex anatomies and if you have a high risk for embolization, I guess you need to look at proximal protection as your stronger option. We're also talking of seat belt and airbag together. Like say you use a proximal protection as well as the distal protection in a given case where you seriously think of a high embolic load and you can work on it. Even with proximal protection, I guess the current studies are showing a success rate of around 95% plus, pretty close to the distal protection device. The strong point in favor of carotid stenting is the recurrence rate. I think in carotid stenting, the recurrence rate is just around 5%. You take many studies across the globe and you realize that the success rate, which holds in long run, is clearly above 95%. And here is a SAPPHIRE follow-up of over 3 years, which puts stent actually ahead of carotid artery surgery follow-up. So we have stents which are actually going very good results. And the TLR, which is always pain whenever we talk of percutaneous intervention, is actually better in all these studies compared to the surgical studies. So once you achieve an acute results, the stenting appears to hold better in long term. This is a book case where actually they have done a carotid endarterectomy, but when it comes to redo kind of procedure, stent is preferred over a redo carotid endarterectomy. So one surgery, next procedure has to be stent. SAPPHIRE, as you know, is a major landmark trial for carotid stenting. This was actually a high-risk surgical subset around 2004. What they did is they had a sort of a randomized major subset, but they had a stent registry where actually surgical refusals. And even in these surgical refusals, the event rate appears much better than the results offered by surgery in the randomized arm. I think this was a very strong point in favor of carotid stenting. In SAPPHIRE, the endpoint, primary endpoint was taken as myocardial infarction. Apart from stroke and death, which is generally accepted, myocardial infarction was a unique endpoint which SAPPHIRE took because they were dealing with high-risk cases. High risk, not necessarily from the neck angle, high risk because associated recent angina, recent myocardial infarction, and so on. So this was a strong point which is not included as a primary endpoint in many other trials. And most of the difference thus actually comes out of this chemical myocardial infarctions in the CAS subset. So it was not the event rate which was related to carotid which actually helped SAPPHIRE to stand out, but it is the chemical myocardial infarctions which were there. In SAPPHIRE, the 3-year long-term follow-up also looks better. As I told you, EVA 3S was a strongly surgically oriented result. This was a French study, a sizable number in both the arms. This was done by the French ministry, and the study was actually stopped because the result in the endarterectomy arm was far less compared to the stenting arm. There are a lot of criticism for EVA 3S study. The surgeons performing were actually, they had performed a sizable number of cases, while the interventionists were actually more like inexperienced, or even some people call them amateurs, because some of them had not performed a single carotid stenting and they were allowed to perform under a proctor's help. So there was a lot of criticism. Only 16% of these cases were done by people who had done more than 50 cases of carotid artery stenting. So EVA 3S, the interventionist experience was considered a very strong negative point. As you know, that you have to have a good experience to come down from an event rate of 10 to around 1%. And there are many studies which tell us that this is from Woolley's analysis. People who have done less than 50 carotid stenting, the event rate could be more than 4, while those who have done 500 plus, the event rate can be as low as 1.5. So it goes to say that experience is of paramount importance. Also in EVA 3S, the first 73 cases were done without protection. And in this, the event rate was very high, 27% against 8.6% in the protection arm. So there was a big difference in the first 73 cases, though finally, after 73 cases, protection was given for everybody, ending up with 92% people ultimately getting a protection throughout the study. How to interpret the EVA 3S is an issue. Following this study, the reimbursement for carotid stenting was not allowed in France. And there are many people who believe that antiplatelet therapy was also not given. Dual antiplatelet therapy was not given. Only aspirin was given. So these were negative factors. The protection device was not used. Inexperienced interventionist, not always a double therapy. And enrollment was overall considered far slower, with many times centers doing just about 2 cases in 1 year time. So overall it was felt that these were strong negatives, but people also feel that isn't this more or less a worldwide real practice scenario? And that's why there are many people who believe that what happened in EVA 3S is what we see in day-to-day life. Like this is analysis from New York State, 1995. Only 48, almost half the cases are done by people who are doing 1 to 5 cases per year. So world over, people are not hugely experienced before they touch the carotid. The SPACE study was actually a European study. The strong point of this study is a number, about 1,200 cases were sort of randomized to surgery. These are again a symptomatic group. Even in this, the comparison of event rate in percutaneous intervention and carotid stenting was not too far, but this was primarily an inferiority trial. The p-value for non-inferiority was only about 0.9%, and overall verdict was in favor of carotid endarterectomy. So carotid endarterectomy was the main point. This study was also stopped midway through. This was more due to lack of funding. And some of the liabilities which go with this study are the end protection device was used only in 27% of cases. So majority of them did not get the end protection device, and this thus becomes a very strong negative factor. There are many who also believe that the results of vascular surgery were around 6%, which is almost as bad as what it was seen 15 years back during NASCET days. So there is no real change in surgical results from NASCET days to now, and that's why people feel that this may not reflect really the true real-life scenario. The SPACE, however, was good for octogenarians, people who are 80 plus. Surgical arm clearly did better in SPACE. We all know that in elderly we get reduced cerebral reserves, and all the trials have shown that what you do for less than 80 years does not hold true for more than 80 years. And people who are above 80 years have a high complexity with percutaneous procedures. We all know that the carotid endarterectomy has many other limitations too. We have cranial nerve injuries, we have bleeding, we have wound infection, we have concurrent myocardial infarctions, peripheral nerve injuries sometimes could be quite serious. And we also have high lesions as well as low lesions, high getting into the level of C1, C2, while low below C6, C7, which can't be addressed with surgical procedures very easily. These are also the hostile necks, which cannot be addressed by carotid interventions. And surgery at the time of bypass surgery can have a very high event rate, almost to the tune of 11%. The carotid endarterectomy is also not good. If you have contralateral occlusion, the event rate could be as high as 14%. And overall, it is felt that whenever you have a contralateral occlusion, the stenting is a preferred option. I think overall, when we compare carotid stenting, we must also give a lot of importance to medical treatment, especially with statins, which have shown that we can achieve decent results if you're very aggressive. There are these issues that asymptomatic patients, whether we leave them on medical treatment, and this study from Galway indicated that there is a comparison for these asymptomatic patients, surgery, stenting, and aggressive medical treatment. It was realized that the surgery did best, second came the balloon, and worse was the medical treatment arm. So even for these, I guess medical treatment is not good enough. Asymptomatic critical stenosis should be addressed and could be addressed with either angioplasty, but better by surgery. There are some bad actors even for angioplasty, and some of these bad actors are actually tortuous vessel angulated lesions and so on, especially calcific lesion, as in this case you can see a dense calcium in this area. However, with various kind of techniques, including double wire, special balloons, we are able to achieve decent results even in heavily calcified vessels. Overall, whatever EVA 3S and SPACE taught us, the angioplasty numbers world over continue to grow. And though the science sort of indicated that we should make a turn a little bit towards surgery, the numbers continue to grow towards angioplasty. Well, you and I, we could strike a balance in certain cases where percutaneous intervention probably would emerge as a better option compared to surgery. And these could be, so interventions could be preferred where there was a restenosis, there's a radical neck surgery, there is high lesion, low lesion kind of situations, while cases who are tortuosities, poor access, there are problems with antiplatelet therapy, severe calcium, arch anomalies could be better done with surgery. And there are these cases which lie in between, which includes supraelderly, string strains, thrombus, and acute or recent strokes, which I guess could go either ways. So you and I probably need to use our wisdom. We have to have event rate which is going to be less than 3% in asymptomatic cases and less than 6% in symptomatic cases if you have to look good and you have to look better than the medical treatment. So avoid over-enthusiasm and avoid over-interpretation. And the best protection you can offer to your carotid stenosis patient is a right indication, good experience, and knowledge and use of right tools. Thank you for your attention.
Thank you very much, Dr. Hiremath. This lecture of yours raises three questions in my mind. A, we are talking a lot about protection devices. Protection device is good, there should be, it is at least gives you a good mental feeling, I have a protection device. But we also know that the people like say Judy Vitek, 0.5% without protection device, Fayaz Scholl, 1.4% without protection device, Klaus Matthias, before he started with protection device, it was 3.1%. Study from Linz, 2.5%. That means it goes a lot towards the experience. We are perhaps allowing the younger group or those who are starting now to go for the intervention before they are adequately experienced in the catheter technique. The catheter technique in the carotid arteries is a totally different ballgame, and we should realize that and we should give value to that. And only after that comes the intervention part. And here the third point, the French study which ultimately stopped their procedures, was nothing but a trap. Nothing but a trap to push out the carotid intervention, the carotid stenting. So that to give many inexperienced guys in it, doing incomplete thrombocyte aggregation blocker treatment, and ultimately bringing out that disastrous result and telling that, okay, now you stop it. That's what my feeling, I say.
Yes, to answer, Klaus Matthias, for example, wrote maybe 2 or 3 years ago, with protection device, we reduce the complication rate by 60%. Fayez Scholl now use protection device in any case. Fayez Scholl.
No,
So
we have Fayez Scholl studies. We know that people are going for, I am also now in favor of protection device.
Yes.
I have nothing against it. But once the protection device is at its prime, okay, I find now today Spider is a good protection device. I use them. But the thing is that, not to think that, recently there was a book was published. There is also written that if a protection device doesn't pass, you don't do the procedure. I don't know how far I can agree with that.
Yes.
I believe that the initial experience of catheterization technique of the carotids is very important, and that should be given much more value. And in the last month only in South Africa, we met with the International Andreas Society, and there we had 4, other than you are also very much at the peak, but there were 4 other speakers also, like Gary Rubin, Klaus Matthias himself, and our Fayez Scholl, and they were all emphasizing, let them do the initial work of catheterization technique. Once they have understood that, they have got that feeling, then the procedure will be much shorter, much precise. We don't sit with your gadgets and garbage inside the carotid.
So you're talking of good experience, but you're not trying to say that don't use protection. Am I correct?
Pardon?
You're not trying to say don't use protection.
No.
I mean,
Definitely
experience
not.
cannot be a substitute to protection. I mean, we have done...
Not protection is good,
Absolutely.
but we should not give only point to the protection. Protection is not always a protection.
I think in 2009 it would look very awkward if I don't use a protection device. I'm not talking just from medical legal angle, but I think the way we feel about it, I think protection would be, there is nothing that you can do. You review your earlier cases where you are done, stent was, protection was not available. You do same technique,
Yes.
everything same, and just a stroke takes place and you just can't do anything about it. So I think I would be very hesitant to do a case without protection today. I think
Yes, today, once it develops like that, it's all right. Today, I am also quite hesitant to do with a protection device, though my initial 86 cases were without a protection device, and I had not even a single major stroke. Because before that, over 15 years, I did regular carotid intervention since 1979.
Shirish, I have a small comment to make. While I am a firm believer that carotid artery stenting is an excellent procedure, the problems have crept in. In the Journal of Vascular Surgery March issue this year, they have presented the US government database for 2006. And it came as a surprise to me that 80% were carotid endarterectomies and only 20% were stentings. Contrary to the slide which you showed, where the expectation was that the stenting would go up. So as late as till 2006, at least in USA, 80% of patients, according to the government database, were still getting endarterectomy and only 20% got stenting. And the second thing is, because funding has been stopped for this procedure in USA, outside of trials and outside of specific indications, I think that is preventing a hindrance for it to grow in the, at least in USA.
No, the question comes there also why they are raising a question, why are they doing it on the asymptomatic patients? Okay, we sitting in India, we don't need to think much about that. Do we get any asymptomatic patient who comes for the treatment? I don't remember. Really, that somebody with a narrowed carotid artery is coming to you for a treatment?
Most of these asymptomatic carotids are, when we are assessing them, prior to a bypass surgery. Like patient is scheduled
And
for a
how many
bypass.
of them agreed for the...
Oh yeah, I mean, if you have a 90% asymptomatic carotid stenosis, we just cannot go for bypass surgery without setting it right. So I think they are forced to agree. I think that's the major subset where I think all of us get asymptomatic carotids, but majority, as you
Well,
correctly
I
say,
have different experience. Perhaps they remained with the neurologists, and they are the first people who see, and they are not really always they refer the cases.
I think we must give audience time to interact. Yes, your question, please.
Yeah, I'm a cardiac surgeon and we have a vast experience of doing carotid endarterectomy. We do almost 100 carotid endarterectomies in a year. And most of us, most of the cases are, as you were saying, the cases asymptomatic as well as symptomatic combined with coronaries. And as a group, when we are doing more than 100 a year or so, we have published a data in Indian Heart of more than 850 cases. Plus, we have a publication in anothoracic surgery as well. And our results, as I can say, we have a complication rate of less than 2%. So, the experience does matter. And even in the hands of the surgeons, it's not, if a surgeon who is doing it for the first time, I'm sure, it's really going to be really a mess. But a person who are, the group, we are experienced enough, are doing it on a regular basis. Carotid endarterectomy, I would prefer any day better than carotid, stenting.
I'm glad you said that because I'm 25 years plus in practice.
I think we must
I
thank
also
Dr.
have-
Shirish for his excellent presentation and the debate he has generated. Thank you, Dr. Hireman.